I'm most excited to present or to introduce our next speaker, which is me. I realize I actually had started the day without introducing myself, but I'm Jack West. I'm a medical oncologist and thoracic oncology specialist at Swedish Cancer Institute in Seattle, and the founder of GRACE about 2007. And it's been great to see it grow to involve so many of my colleagues and help so many people. I must say it's remarkably gratifying to have people come up and say that it's made a difference for you. That's what it's all about. Thank you. I also wanted to say that Craig had mentioned that he had learned about ROS1 and commented on it here and there, and that if you work with a lung cancer specialist, you might not need this information. But Craig was the inspiration for the introduction to a talk I've given in the past about the difference that patients can make, because I learned about ROS1 from Craig, okay? So, and I am a lung cancer specialist. I spend a lot of my life thinking about it, but there are patients like you who are the bleeding edge of it, who are learning more about it faster than just about anybody except the people who are sometimes actually doing the research. So I think it was basically online when it was 3, 4, 5 docs who knew about this stuff. And so even if you do have a lung cancer specialist and you're at a center of clinical research, you cannot underestimate the value of informed patients. So I will be speaking just as we head into a little Q&A and discussion with Bonnie and Craig about cost and access, because it's a challenging issue now. And I don't think that we can really talk about the promise and the value of these therapies without contending with this practical challenge. Outside of clinical trials, which are a great way to move the field forward, but to also get drugs free, once they are commercially available, the cost has been going up, and you can see that trend over time for cancer drugs. It's been really quite rapid, and we are really now eclipsing what was previously a $10,000 per month barrier, and that's going away, and you can see now that there's some dots that far exceed that. It's becoming one of the leading controversies of incomprehensible prices, a real challenge in paying for these, whether it is on a personal level for patients or families, or insurers covering them and raising the cost of Medicare coverage or those premiums going up. This was just the story 2 days ago. I was here in Boston, and this is not an EGFR ALK drug, but this is about the commercial availability of, which is I think nivolumab in Japan. But the one leading aspect of the story was the cost of $143,000 per year for an average patient. And so this is the Wall Street Journal. It's not unfriendly to industry, but this is becoming now a part of the headline is great drug, can we afford it? And it's hard to not contend with these issues. I want to pay homage. Alice Shaw had published the work that led directly to the approval of ceritinib in a very timely way in late April, but at a cost of $13,000 or so per month. Now, it can go down, as we were hearing, if really the approved dose is higher than most patients need or necessarily will tolerate well, and the price goes down accordingly. But it's still a pricey drug, and that is going to be a barrier in many ways. And I wanted to talk a bit about how this really comes home to roost with the Lux Lung Studies. And this was a pair of trials by Boehringer Ingelheim of afatinib in EGFR mutation positive patients first-line therapy compared with standard chemotherapy in patients known to have an EGFR mutation. The Lux Lung 3 trial was a global study, Lux Lung 6, an Asian study, and it's a 2-to-1 randomization in both cases of afatinib versus standard chemotherapy. And one key point, and we had debated about why there might be a survival benefit seen in the pooled results from this, was the crossover, which was a little low, lower than we would hope to see in a lot of Japanese studies with gefitinib, for instance, Iressa. You would see 90-some%, even approaching 100% of patients cross over from chemotherapy to Iressa if they were known to have an EGFR mutation. In the Lux Lung 3 global trial, the crossover rate to an EGFR inhibitor after chemo was 75%. In the Asian study of gemcisplatin versus afatinib, it's only 56%. And that's really discouraging, I think. And what's more striking is, but not surprising, is that, as you might expect, it matters where you're being treated. It matters the healthcare system and the coverage, because if you were in a country that had good coverage for an EGFR inhibitor, the crossover rate to this therapy is 91%, but it's only 52% if you were in a country that did not have good coverage for these agents. We're talking about EGFR inhibitor therapy for patients with a known EGFR mutation. And of all the controversies we've discussed today, giving an EGFR inhibitor to someone with a known EGFR mutation is not one of them. That is one that is considered an absolute truism. And yet these people were known to have an EGFR mutation and never got the opportunity to get it. And it was because of cost issues. We had several speakers today talk about this trial by Kato and colleagues from Japan of Tarceva alone or with Avastin in EGFR mutation-positive patients. I have been personally impressed by the progression-free survival difference that I would consider clinically significant, but it does come at both a toxicity cost and it comes at a real-world cost of actually about $10,000 per month in acquisition costs, and that translates over the course of what was typical treatment was 16 treatments difference, was $120,000. And the challenge that I see as well is that this is not necessarily always being discussed in a direct way, but it leads to a bias in people's ability or willingness to give these therapies. How much evidence is needed to change practice, I think matters whether the drug is very expensive or not. We've seen with prostate cancer that Provenge, which is an immunotherapy that's been approved for years, but costs $93,000 total for 3 treatments, is really quite underutilized. And I think it's because of a bias that it's just not fair pricing and it's just not worth it. And I'm concerned that when you have drugs that cost this much of a difference, it's a real barrier in actually getting what is the most effective therapy. And so we are talking all this time about finding the right treatments and identifying the right targets, and that's been a historical bottleneck. But it's frustrating when we know we have a good target and we have an effective treatment for that, but when the cost exceeds $10,000 or more per month, it was a barrier for afatinib, which is comparatively a bargain at mid-6,000s, $6,300 or $6,000 per month, which is a lot of money, but it's only a more acute problem when you're talking about the price for new drugs being introduced at $10,000, $12,000, $15,000, or a course of immunotherapy that is going to cost over $100,000 per year. And I think that's a real bargain, a real challenge. And what we're not having constructive conversations leads to this bias of how much data do we need to accept it or recommend it to patients. And the challenge is that the bottleneck is becoming actually delivering it to patients. It's not clear how much of a burden and a barrier this is to patients, caregivers. I want to introduce that question to people as we move into the Q&A session. But I can certainly say that as we look at the data with afatinib and see that if you're not in the right country with the right coverage, 48% of the patients died without getting an EGFR inhibitor. That's a really disturbing thought to me. So I think that this is really part of the discussion as we find these agents, as it's not just about finding the most effective treatment, but actually getting it to the patients. So my questions to you are people unable to get the needed agents because of cost? Is it causing significant psychological or financial stress? Are you getting second mortgages to pay for certain agents? How do you see the cost debate? And how much does cost limit access even to trials? And there's issues with travel, there's issues with all sorts of things, but does the cost of potentially being financially responsible for flying back and forth or complications limit things? Is it more of an issue of interest in research, education? What are the barriers? So I don't pretend to have answers to these big questions, but I open it up and would say that at this point in the closing portion of the day, we'll have one more Q&A session. I'd like to welcome back, bring up Bonnie and Craig, and again have people write questions that you have, and please offer them to Seth and Nancy, I believe, is still here, and they'll be looking for them if you want to hang them up. And feel free, people can also give their own comments too as well. But I'd like to do that, and then we'll have some closing comments and take things from there. So let's, Craig and Bonnie, please.